Good afternoon. It is Wednesday, October 30th, 2024, and this is a Protect Our Province BC live briefing on Long COVID, a mass disabling event. I am Dr. Susan Coe, a family physician working in Richmond, BC for 31 years. I am a clinical associate professor at UBC and a member of Protect Our Province BC. Protect Our Province BC is a nonprofit grassroots organization consisting of doctors, nurses, health scientists, and community advocates striving to keep the people of British Columbia safe by sharing accurate scientific knowledge about COVID-19. We also advocate for the BC government to do more to protect the health and prevent chronic disease and disability for everyone who calls BC home, starting with the most vulnerable among us. We begin by respectfully acknowledging that we are broadcasting from the traditional, ancestral, and unceded territory of the Coast Salish people, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. We are grateful to the Indigenous peoples who have cared for these lands since time immemorial. As settlers, we commit to do our utmost to uphold the Truth and Reconciliation Commission and work towards the 94 calls to action. Our topic today is long COVID. The World Health Organization defines long COVID as the continuation or development of new symptoms 3 months after the initial SARS CoV-2 infection, with these symptoms lasting for at least 2 months with no other explanation. The Chief Science Advisor of Canada, Dr. Mona Nemer, released a report in September 2024 on post-COVID-19 condition and its continued impact on individuals and society. From this report, 1 in 5 Canadian adults have developed post-COVID condition after an infection with SARS CoV-2. Risk factors cited include female sex, acute COVID-19 severity, and repeated SARS CoV infections. Studies show that more than 90% of long COVID cases occur after mild COVID infections and often in people who were previously healthy. A Statistics Canada survey revealed that 100,000 adults in Canada were unable to return to work due to post-COVID condition, with an additional 600,000 people having reported missing school or work for an average of length of 24 days. Dr. Nemer has called COVID a mass disabling event. Individuals affected by COVID, post-COVID syndrome, reported facing dismissiveness, stigma, lack of knowledge, and inadequate support when navigating health and social systems, including for disability insurance. Dr. Ziyad Al-Aly, a leading COVID scientist, said in his testimony during the January 2024 U.S. Senate hearings on long COVID, long COVID affects people across the lifespan, from infants to people who are 100 years old, and across all demographics. It affects almost every organ system, and the burden of disease and disability of long COVID has now surpassed both cancer and heart disease. Today's discussion will be focused on long COVID in adults, but children have not been spared from long COVID. And in the August 2024 study in JAMA, it was estimated that 25% of children in the U.S. have long COVID after a SARS CoV-2 infection. For today's briefing, we are joined by Dr. Ric Arseneau. Dr. Arseneau is an internal medicine specialist and clinical professor with the UBC Faculty of Medicine. He is a physician lead for the Provincial Echo Education Program for long COVID. He is also the former director of program planning for the Complex Chronic Disease Program at BC Women's Hospital. He is a director of one of the only long COVID clinics actively seeing patients in BC. We are also very happy to have Kayli Jamieson with us. Kayli has been a long hauler since December 2021 and is also a communication master's student at SFU, writing on biopolitics and long COVID. She's also a long COVID research assistant in SFU Health Sciences, leading studies on long COVID in British Columbia. And finally, we're also happy to have Connie Chan with us. Connie became sick with long COVID while she was working as a bedside nurse at VGH in February of 2021. Connie is currently working part-time as a discharge planning nurse at UBC Hospital. Can we bring them on the screen, please? Thank you so much for joining us today. So, Kayli and Connie, could you tell us about how you came to have long COVID and about your journey with long COVID? We will start with Kayli, please.
Hi, everyone, and thank you, Susan, for the introduction. So I first got COVID in December 2021 during the first wave of Omicron when it hit the scene in BC. It was a mild to moderate case, and I thought I had recovered, but I experienced brand new symptoms weeks later, and most notably, this was extreme debilitating fatigue where I couldn't even move, and I just lie on the floor. I'd have to be moved to a couch or a bed. I had super high heart rate and palpitations. Even walking 1 block at a slight incline to the bus stop would give me 178 beats per minute. also breathing issues, tinnitus, internal tremors, and more. And I'd always heard of long COVID, but I didn't realize it would occur to me. So I tried to get a referral to the public clinic. I had to go to the CDC. Once I found my house, I started having exertion malaise and tracking my heart rate for pacing. But my symptoms got way too physically debilitating, and I had to leave my job at the library, which was devastating because I'd been there for like 7 years. And for over 2 years after that, I maintained hybrid and remote work research jobs, such as my research work in SV Health Sciences on long COVID in BC. But I went on and off medical leave from my master's at SFU as the brain fog prevented me from understanding my own work or dense theory. But long COVID impacts every single aspect of my life, especially in my relationships. So not everyone understood my limitations or how every day my body would show up differently for me. At my worst states with PEM, I could only leave the house once a week or even once every 2 weeks, and it would take significant recovery time afterwards. It completely upended my life and how I saw my identity, as I used to be super busy and involved in many things and very sociable and outgoing. And my friends and family believed me at least, as they trusted me on the science. But what upsets me is how they don't consider themselves to also be at risk, and I'm some strange exception. And around a year ago, I tried low-dose naltrexone at zero point 0.5 mg, and it brought me back significantly from my brain fog and fatigue. I tapered off of it this past spring as I felt it plateaued, didn't really do much anymore. But I made some other life adjustments and pacing, and this summer I found miraculous improvement. But I still do most definitely have long COVID.
Rory, thank you very much for sharing that with us, Kayli. And Connie, would you also share how you came to have long COVID and tell us your journey with long COVID?
Thank you. And hi, everyone. So I caught acute COVID at my work at an outbreak at the end of February 2021. At the time, the only thing that pointed me to knowing that I had COVID was my test result. I had no other symptoms. During isolation at the time, I started being cautious of my symptoms and how my body was reacting. At most, I would have a very, very mild chest tightness feeling. And then towards the end of the 10th day isolation, I started noticing that when I was just even doing warm up activity in my room, I was already huffing and puffing. My chest felt really tight and uncomfortable, and that had never happened in my life before, even when I was not fit or not exercising for long periods of time. So that was something new for sure. I rested a bit, had some food, but unfortunately, it didn't go away. It was lingering the day after and maybe the second day as well. And then that was when I realized that was my first crash, which is really common in long COVID population. It's the fatigue and exhaustion after and overexertion activity. And my first breathlessness episode, it felt like every breath was not enough. Um, Even when I was starting to slow my pace down on breathing, focusing on deep breathing, everything I had known, nothing worked. At one point, I tried puffers, didn't work, and it only made me more anxious and scared, and all the other symptoms kind of elevated, which included high heart rate. And then along with that, I noticed that I also have dull chest pain the first 6 to 8 months, insomnia, even when I was super exhausted and crashing almost all the time in the beginning. Um, my concentration and memory were also affected. At first, I didn't notice it, but upon prompting and just looking at myself in general, I just realized I wasn't who I was anymore. I'm always someone that's quick and on the tip of my toes, a busybody, had great memory. I could juggle things at the same time, like many things at the same time in a fast-paced environment, under stressful times, no issues at all. But then now I would lose my train of thoughts. I find that when I read a light read, I would have to reread the same line several times. I would repeat conversations with my friends that I thought never happened before. I would even have trouble finding words like a post-stroke patient. That was a real eye-opener for me. I did not expect that. Um, it could just be doing the one task of the day to trigger these overexertion symptoms, whether it's simply blowing dry my hair while standing up, speaking one word at a time at my worst, talking too fast, walking and talking at the same time. Sometimes I'm even triggered by something as thoughtless as changing into a set of clothes. And I'm not talking like about a ball gown or anything. Just, switching out a top and a pair of jeans, and then I'm like, "Oh my god, what's happening?" Um, Taking a flight of stairs or walking uphill was definitely out of the picture for me until I think at least after a year or so, give or take. And even so now with those situations, I still have to be cautious. I have to pre-plan where I'm going, nothing spontaneous. I have to pace myself, because I learned through trial and error that pacing is what helps prevent those crashes from happening. And also being aware of my body, what it's telling me, how fast I'm doing activity, how often do I need to take a break, and how long that break is. Um, as with a lot of long COVID people, I'm all aspects of my life, whether it's physical, mental, emotional, everything was affected. And in turn, those could also be a stressor and cause me to be in an overexerted situation. It's really hard to wrap my head around it. And some of the symptoms surely have improved and gone away, but others like breathlessness, fatigue, brain fog occasionally still come up. And I'm working within my limit, and establishing new limits have to be done very, very slowly, gradually, as opposed to the usual bodybuilding where people are like, "Oh, you must, push yourself harder, get your health back, and train up and go for a run." I'm like, that's exactly opposite of what I'm told I should be, and that's how I learned it through the hard way as well. It was super new. It is still super new situation, but at my time when I had it, nothing was really known about long COVID. So trial and error was my friend for the long time. Like Kayli, I was one of the first few people in my circle that had, COVID and then post-COVID and eventually long COVID, and I was really worried about telling people around me, because fear of judgment, and because it's not very well understood. And then primarily also because I was already so exhausted. For once in my life, I needed to really focus on myself instead of others. So yeah, so far that's my journey, and still battling it every day, but in different degrees.
Connie, you also faced pregnancy, delivery, and having to care for a newborn while struggling with long COVID. Could you tell us about this?
Oh, yes. We had a surprise pregnancy among all this. I love my child. I wouldn't go back to it at all, but it's one of the most challenging things, in addition to having long COVID. So two things at once. During my pregnancy, it was really obvious something was wrong right away. Most people wouldn't be able to tell they were pregnant unless they were keeping track, like on the dot. But I knew something was wrong right away, even when I was working within my newly established limit. I realized that my first trimester I was functioning like someone who was in a third and final trimester, without the belly and everything, without that heavy weighted fetus in my body yet. So I was really scared. I was not sure how much it would affect the baby during the pregnancy and after. To this day, I guess I will never know. For now, he seems okay, but we'll just have to wait and see if something turns up. At the time, my GP and my OBGYN didn't feel that it was wise to follow through with a vaginal delivery. And being a nurse myself, knowing the system and knowing how I was at the time, how low my tolerance is, I 100% agree. But it definitely was an emotional journey for me, even to this day, knowing that I could not give the best to my child that I could have had I not caught this virus. Um, so yeah, and postpartum for sure. The first 6 months, I would say, not even the first three, was hard. Dealing with a newborn, but also having to working within my limits. I had to give up breastfeeding early when my husband returned to work from an extended parental leave, because every drop of milk that came out of me literally felt like every bit of my life force was drained away, and I would be like exhausted for the rest of the day, if not more. So there were times where I definitely have to hit a few of my limits while caring for my little one, just because it was just me at home. And to this day, I still feel an immense amount of mom guilt, and helplessness because I'm not 100% there for my child. I have to definitely modify a lot of ways that when I interact with him or play with him or how I care for him, and be dependent on others, when I know that I could have done it myself in the past if I wasn't in this position. Yeah, so yeah.
Connie, that sounds like a very difficult time for you. Thank you so much for sharing this with us. Kayli, you've gone back to complete your master's as SFU. How are you doing right now?
Yes, I would say miraculously, I am 90% better, but I still cannot exercise or run, and I still have hand tremors, which are evident here. I can leave the house every day. Once again, it's seriously miraculous. I don't take a single second for granted. Even just waiting in line for coffee, I'm like appreciating every moment now. And I worry that it can be taken away if I get reinfected. So I feel like I'm always on borrowed time. If I do get reinfected, I don't know if that's going to reset how far I've come, or if it's going to, or if that will significantly lower my baseline and my energy envelope at the moment. I did return to my master's this past January with a brand new thesis topic on long COVID and biopolitics. I changed my topic as I'm evidently much more passionate about this one now, and I'm currently puttering away on my thesis, and I'm recruiting for my study.
Glad to hear that, Kayli. Um, Connie, you've also returned back to work as a nurse. Can you tell us about your experience returning back to work?
I'm really thankful that I'm back to work and I'm still functioning as a registered nurse, though I'm no longer able to do bedside nursing, unfortunately, because of how physical and mentally demanding that job is, as a lot of you may know. It was really hard. The process is really long in finding out what my limits are, uh, and having to work with my employer and other parties, um, trying to look for job accommodations within my field, but that was able to accommodate my restrictions of having micro breaks, and being more of a sedentary nature in general. Um, Eventually, I was encouraged to look and apply for my own, as I see fit, which I did because I didn't want to give up nursing, even if it wasn't bedside nursing. It meant a lot to me being a nurse because I entered this field out of passion and wanting to help others. And I enjoy working directly with my clients. Unfortunately, I can't do that right now. I do still see clients, but just on a different nature now. But it's still really nice that I get to go back to having a routine, and having a new identity and a work life, as opposed to just recovering at home. It's definitely a learning curve. Being out of commission for at least 3 years now, almost three and a half. A new role, a new unit, a hospital that I've never worked at, new routine, new limits have to be established, and I have to be extra cautious because, like Kayli, one infection could set me off again. And even if it wasn't COVID, it could be, the flu, it could be cold, anything, allergy triggers, not enough sleep, anything. Then everything would get pushed back, and I would be fatigued again, and I would be very worried about job security, because I will always be worried whether I'm still competent, whether I'm doing the best I can. So yeah, I'm still slowly getting used to it. It's definitely taking a lot longer than I used to, but I'm getting there.
Connie, good for you that you returned back to work to something you love. But I know you work part time, and you told me that after the third day, it's sometimes very difficult for you. Can you tell us about that?
Yeah, I forgot to mention I'm only able to work part-time now. It's not a choice. It's what I find happens towards that third day-ish, so to speak. I find that I'm hitting really close to my limit where I would start to have headaches. By the time I come home, I would be very tired. I would have to rest for quite some time in the beginning, and then slowly the symptoms are a bit better since the third week into my rotation, but still, it's still lingering. So I'm very hesitant to push to going back to full time. So yeah.
Thank you very much, both of you, Kayli and Connie, for sharing your stories with us. They're really compelling stories. Now we're going to hear from Dr. Ric Arseneau. So, Dr. Arseneau, thank you so much for joining us today. StatsCan reports that 1 out of 8 Canadians adults who sought healthcare services for long-term COVID-19 symptoms reported receiving only 1 out of 8 received adequate care. You're a physician at one of the only long COVID clinics in BC. So, what inspired you to care for this patient population?
Sure. Before that, I answer that question, I just want to clarify a couple of things. First is that I was the physician lead for the COVID education for the province. That program is now completed and hasn't been up and running for a couple of years. The second thing is I would call my clinic a long COVID clinic. It makes it sound a lot more impressive than what actually it is. There's only 2 of us, me and Dr. Jane McKay, who do virtual care around the province. And we have a bunch of people who help us with various things, but how we got into this is that both of us have been taking care of patients for decades with chronic fatigue syndrome, also called myalgic encephalomyelitis, fibromyalgia, and related conditions. And so I want to make a distinction between post-COVID and long COVID, because although there isn't any accepted naming convention, we should at least keep these concepts in mind until the naming convention is approved or decided upon. Dr. McKay and I use the same naming convention as the Mayo Clinic in Rochester. And what they say is that post-COVID is anything that can happen after COVID. And they break that down into 3 categories. The first category is people who have tissue damage or metabolic derangement. So if you have lung scarring, heart damage, blood clots, diabetes, loss of taste or smell, those are all direct viral damage. The second category is people who develop mental health issues like depression, anxiety, and PTSD. They reserve the term long COVID for the last group, which is the post-viral syndromes. And so some of us, including myself, would argue that we did not need the name long COVID because we've been taking care of post-viral syndromes for decades. And the post-viral syndromes exist along a spectrum. Some people will have very mild version, like the young adults who get mono and are out of commission for 6 months to a year, all the way to the people who have more severe versions of post-viral syndromes that fall into distinct categories. And those include chronic fatigue syndrome, fibromyalgia, mast cell activation syndrome, postural orthostatic tachycardia syndrome, and others. And so the distinction between post-COVID and long COVID becomes really important because it causes a lot of patient confusion. It also causes a lot of confusion because it makes the medical literature difficult to interpret. So for instance, Dr. Kuo at the beginning said that disease severity was a risk factor for long COVID, but really it's a disease risk factor for post-COVID, the virus damage kind, not long COVID, the post-viral kind, because we have over 1,000 patients in our clinic, and I've only had 2 patients out of that who were hospitalized and only 1 patient who's been to the ICU. And so it also affects policy decisions because when the post-COVID clinics were open in this province, when they were really busy, at some point they made a decision to only see patients who had been hospitalized. And that would be great for identifying those who have lung scarring and all that other stuff, but it means that they excluded all of the patients who had the post-viral syndromes, which have been described really well by Connie and Kayli. So just for clarification, Dr. McKay and I don't have a long COVID clinic or a post-COVID clinic. We see patients with chronic fatigue syndrome, fibromyalgia, and the post-viral version of long COVID. So that's how we came. In the first week of the pandemic, I was in Mexico, and I told my partner, we are going to see a tidal wave of patients, because the literature told us way before that about 10% of patients who get a severe, different kinds of virus are more likely to develop a post-viral syndrome. So we were kind of flabbergasted when we'd hear on the news, what is this long haulers? Where does this, it's been around for decades, and we've known about it for decades. And that's why I said many of us don't think the post-viral version actually warrants a new name.
Thank you very much for that very detailed answer to that question. So you mentioned that you have about 1,000 patients at your clinic. What do you think your current waiting list is?
Well, we have 1,000 long COVID patients, but we have 4,000 active patients.
Okay.
And we have an unusual clinic in that our patients can participate in anything that we do even before they see the physician. So they can start getting education, participate in groups, learn about medication. The only thing that we can't do is prescribe until they see either me or Dr. McKay. So right now, the wait list to see me or Dr. McKay is somewhere between 9 months and a year.
Mm-hmm. Yes, I think that's been really helpful. I know that some patients that I've sent to see that they can participate right away. It's a really great system. As a family doctor, I seem to be seeing at least one new case of long COVID per week. And the U.S. insurance companies are reporting a huge increase in disability claims in the last 5 years. So do you think the prevalence of long COVID is increasing in BC and in Canada?
Yeah. So, people are under the impression that the COVID pandemic is over. And so the numbers may have reduced, and with vaccination, we see a reduced number of people developing long COVID. That's a plus for vaccination, even if it doesn't, you're not at risk for hospitalization or death. Is that it's now considered between 3.5% or 7%, depending on where you are. And so we're going to continue to accumulate a group of patients who have long COVID indefinitely.
For sure. Now, long COVID has a constellation of more than 200 associated symptoms affecting almost every organ system. And we're seeing increasing numbers of people who have symptoms they don't even realize are long COVID, and sometimes their physicians don't even realize this. Could you tell us about your approach to how you classify these wide-ranging symptoms in the patients that you're seeing at your clinic?
Yeah, so on the one hand, it sounds overwhelming when you say that over 200 symptoms have been described. But many of those symptoms are just different ways of saying many of the same things. And so if we're looking at the post-viral version of these conditions, they tend to present with 5 factors. One is fatigue, with post-exertional malaise if they do too much, pain, sleep disturbance, brain fog, and unexplained symptoms. And the vast majority of the unexplained symptoms fall into what we call dysautonomia, dysfunction of the fight or flight system, neurologic symptoms, and gut symptoms, although there are many others that are possible. So pain, fatigue, sleep disturbance, brain fog, and unexplained symptoms, to me, is one of these conditions until proven otherwise.
October is Dysautonomia Awareness Month, and studies have found that long COVID patients suffer a high rate of autonomic disorders with a common symptom called POTS. Could you tell us about this symptom?
So POTS, P-O-T-S, it stands for postural orthostatic tachycardia syndrome. So you don't really need the O, because postural and orthostatic mean the same thing. It means that when you go from lying to standing. And what happens with these patients is when they go from lying to standing, their heart rate increases by 30 beats or more. As your heart goes faster, each beat pumps less blood. So a fast heart rate only helps to a certain extent, and after that, you actually start getting less blood to your brain, and you feel dizzy, and many patients go on to faint.
Since we last spoke, has there been any research about how we can diagnose long COVID, or any research causes or mechanisms you'd like to share with us?
A tough one, right? Because if you use long COVID in the post-COVID sense, it's a whole bunch of different conditions. And even in the post-viral sense, it's the post-viral conditions, chronic fatigue syndrome, fibromyalgia, POTS, MCAS, don't have any diagnostic tests. And all of the tests that are traditionally available to physicians come back completely normal. There are a lot of abnormalities, but those are only available in research lab tests. And so that most of these patients get told there's either nothing wrong or we can't find anything.
Mm-hmm. Now, what are some of the current treatments you're recommending in your long COVID clinic?
So right now, for the treatment of long COVID, it's mostly repurposed treatments. And so if a person fulfills criteria for chronic fatigue syndrome, we will use medication that we've used for that. And that's why, if we look at, quote, evidence-based guidelines, you'll get the sense that there's nothing you can do. But if you look at, okay, I'm going to treat POTS, I'm going to treat the pain of fibromyalgia, I'm going to treat the sleep, most of our patients, if they haven't tried them, have 15 to 20 medication options, not to mention other treatment options that might help. And was mentioned earlier, naltrexone is one of the ones that is commonly used. Unfortunately, even with chronic fatigue syndrome, there's not a lot of evidence for the treatments. And so we often guide our recommendations on a reality-based medicine as opposed to evidence-based medicine. And we look at three factors. What's the cost? What's the risk? And what's the evidence? So something that costs nothing and is low risk, we don't need a lot of evidence to try that. Something that has high cost or high risk, we would want to wait until there's large randomized controlled trials. And most of the treatments that we use extend within those two, and that's how we make a decision to use treatment. Other things like fibromyalgia has a lot of research evidence in terms of what we can use for pain and other things. So there is a lot of treatment that we can use. There's no specific treatment that has been invented for long COVID or these conditions. In fact, right now, there's a lot of drug companies that have abandoned looking for stuff for long COVID because they think it's too high a risk. So even the Recover initiative by the NIH is really looking at repurposing medications and repurposing treatments that have been used in other similar conditions.
Mm-hmm. Thank you very much for that answer. So the July 2024 study by Dr. Ziyad Al-Aly and his colleagues on post-acute sequelae of SARS CoV-2 infection in the pre-Delta, Delta, and Omicron eras found that unvaccinated people were more than twice as likely to develop long COVID. Can you comment on this?
Sure. So let's just define what PASC stands for, post-acute sequelae of COVID. That was one of the proposed names. Luckily, it did not catch on because it's a mouthful. And so that post-PASC or post-acute sequelae of COVID is now what we would call post-COVID conditions. So that includes all the things, the tissue damage, psychiatric, psychological, and the post-viral syndromes. Can you repeat the question? Sorry.
So they found that unvaccinated people were more than twice as likely to develop long COVID.
Yeah, so that's a really important factor, right? Because often people, like was said earlier, don't think that they're at risk because they're not old, they don't have diabetes, they're healthy, they're at risk for long COVID. And most governments have focused on preventing death and preventing hospitalization. They haven't looked at preventing morbidity. And so morbidity is a person who has really bad consequences but doesn't die. And so losing your job, losing your friends, losing your income, those are bad morbidities. And so reducing it by 50% is huge. And that's why I think the recent decision by the government not to purchase Novavax this season is very unfortunate because many patients with long COVID are sensitive to mRNA vaccines and do much better with the Novavax vaccine, which is the old protein type as opposed to an mRNA vaccine. That means a lot of patients are not going to be vaccinated. And if we think about if you already have COVID, getting COVID again means that you may lose half your function or more. So if you're already down to half, a half of a half is a lot. And so none of those conditions are actually being looked at. So, for instance, Paxlovid, the antiviral, and metformin, a diabetes drug used in patients with acute COVID, reduces the chances by 50% to develop long COVID, post-viral type. So that means that the people who are getting it in our province does not include patients who have pre-existing long COVID. But many of us prescribe it because we believe that preventing morbidity in a person who's already lost a huge amount of function is important, just like preventing death and hospitalization is important.
I could not agree more, Ric. Thank you for that answer. Kayli and Connie, what experiences have you had with long COVID clinics? Maybe Kayli first?
Sure, yes. So I think the BC post-COVID recovery clinic is useful for beginners who don't know much about long COVID. They need that foundational understanding of what it is and its associated syndromes. And I helped conduct a study in how long haulers navigate the healthcare system in BC, and I carried out around 50 interviews and focus groups. We heard mixed experiences from the patients and their caregivers and care providers. While the webinars at the clinic may be educational and an informative primer, for some people, there are no treatments offered at that clinic. Previously, there were regional clinics for each health region in BC. This became amalgamated into one centralized online clinic in March 2023. And it focuses on this self-management style approach. Some people fell through the cracks in this transition or shared that they miss having a long COVID physician attached. Through my interviews, though, I did learn about things like low-dose naltrexone and Dr. Ric Arseneau, so I got referred to him, and I had my first appointment with him earlier this year. And word has spread among long haulers in BC about his clinic's usefulness, and like as you mentioned, like the webinars that they offer, because you don't even need to have your first appointment with him before you can access such resources. So yeah, the medications as well, like having access to that is important. So he and Dr. Jamieson are doing invaluable work here in BC.
I agree. Thank you very much, Kayli, for sharing that with us. Connie, can you tell us your experiences with the long COVID clinics?
I had a very similar experience as Kayli. I was also at the post-COVID recovery clinic under PHSA. I have to agree, it would have been more useful had it been my early phase of battling this condition. Unfortunately, at the time, they had a really strict timeline and criteria for anyone who would be called eligible to get accepted or even waitlisted. I think at the time I had to wait up to 6 months to become eligible on paper before we could even apply, and then almost an entire year before I was formally admitted, saw my first consult, and then have access to those workshops and whatnot. I think by then, between my GP and myself and other support that I've worked with my employer, I've already picked up a lot through those sources already. And I was hitting a lot of walls still. So then I think by then, my GP and I thought, okay, why don't we give it one more shot? We heard of Dr. Arsenault's clinic. So I was very fortunate as well to be accepted in this clinic. And it really was a big surprise to me that I was able to access all these resources, workshops, on self-directed, on my own before I even met Dr. Arsenault for a first consult. I've never heard of this. Is usually a meeting first and then everything else after, if there's anything after. I was definitely overwhelmed, no doubt, but it's because there was so much resource. But taking a step back and really seeing it, it's really beneficial. As a healthcare professional, I'm sure a lot of us can relate as well. It's a great ideal concept as well. And having to see this in action is amazing. Basically, we're empowering individuals, getting them to be more proactive with their own care because, at the end of the day, it's our own health and our body. So this is truly the best case scenario. And yeah, just navigating through new educational opportunities, even though it's been over 3 years now for me, there's still always something new to learn. And I agree, like I was really fascinated by how much even the drugs that I relearned through his workshops, and I was surprised to know how much cost-effective options and alternatives there were. even simply, salt and water for POTS. I mean, yes, it's gross, but you don't have to really take a drug if you don't want to. So, and it worked. So why not? So, yeah, that was it still is an incredible experience, and I wish I had connection to this group of people earlier too, because
Mhm.
it's really hard to find anyone to talk to who really understands what you're going through, um, and to have this support network as well with other clients. So yeah.
Thank you for sharing. And Connie, I totally agree. Um, I actually use some of his consults to help my other patients um, while they're waiting to see him. So it's very, very helpful. Um, so, Dr. Arseneau, in my practice, I'm seeing many sad cases of people who were previously healthy and are now disabled with long COVID, and they're not able to work due to severe memory loss, shortness of breath, or extreme fatigue, or other such symptoms. What percentage of your patients are returning back to work and with their day-to-day lives?
Well, keep in mind that these post-viral syndromes exist along spectrum, and the time it takes to get a diagnosis, anybody who has a mild version would not have seen me. And so my population is skewed to the more severe persistent group of patients. But in my population, upwards of 90% of people are not working.
Thank you. And what kind of challenges or obstacles are your patients facing?
So most of them are actually getting denied disability. And often, if they don't have a diagnosis, the insurance companies use the subjective symptoms, no diagnosis, no medical evidence of disability. And then even if they do have a diagnosis, they often either don't get disability or get disability for 2 years. And then when the definition changes from own occupation to any occupation, they get kicked off. So
Mhm.
Dr. K and I spend a huge amount of time in advocacy, in doing paperwork, and in medical legal cases. And so I probably have 500 plus forms to fill per month, and many, dozens of appeals claims to participate in.
Yeah, as a fellow physician, I totally echo uh, your advocacy and all the forms that we have to fill out these days. I completely agree. And in line with this, so as of September 30th, 2024, there have been 23,092 WorkSafe COVID claims, but only 18,410 have been accepted. And from the WorkSafe website, quote, on July 26, 2024, Dr. Bonnie Henry, British Columbia's provincial health officer, ended the public health emergency for COVID-19 and rescinded all related orders. As a result, a presumption that a claim for COVID-19 is work-related will no longer apply if the exposure occurred on or after July 26, 2024. Dr. Arseneau, could you comment on this?
Yeah, so it doesn't make sense, right? It doesn't take rocket scientists to say, let's look at an analogy. So, compared to 25 years ago, AIDS is no longer a crisis. Let's say the AIDS crisis is over. So any healthcare worker who stabs themselves with a needle and gets HIV is no longer considered to have a work-related injury. I mean, how ridiculous would that be? And it's the same thing. Healthcare workers, nurses who expose themselves, especially those who are working with this population, if they get COVID, and our clinic has an unusually large number of nurses, teachers, and doctors, because those are the people at the front lines. And so to me, I don't know why there isn't outrage out there that healthcare workers who are trying to help, putting their lives at risk, are going to be told now that, nope, sorry, I've chosen an arbitrary date to say that this isn't a problem anymore. The other thing is that you have to put things in perspective. Many people don't know that in our province, the way that WorkSafe BC works is that you can't sue them. And that leads to a huge bias. So I'll just give you some numbers to put in perspective. Because I've been doing this for decades, and I've been helping patients with long-term disability, Canada Pension Plan, PWDTC, I have never lost a single case due to medical reasons, ever. With WorkSafe BC, my success rate is abysmal. It's a little bit better recently, but a couple of years ago, it was around 5%. And so it's telling you that a lot of people who have work-related injuries are not being fairly compensated because there's no external oversight to WorkSafe BC. So if you make an appeal or you make a claim, it's looked at internally, and I've had them say literally, "We don't believe your doctor, period. You're out."
Mhm. I could not agree more, Dr. Arseneau. Kayli, as a master's candidate writing your thesis on biopolitics on long COVID, what do you think about this?
Yes, so my master's thesis is on how BC public health statements and Canadian newspapers have manufactured consent to the quote unquote end of a pandemic, and how the biopolitics of quote unquote immunity and long COVID come into play here. So, for our listeners to understand, biopolitics is a concept famously attributed to Michel Foucault, a French philosopher. And we can understand this as regulatory mechanisms in a society that enables people to make live. Or, in other words, I'm asking who gets to live versus be subjected to conditions of death or mortal harms, which is the other side of the coin, necropolitics. So, when applied to my thesis, it's asking who does this back to normal or post pandemic narrative serve or benefit, and what groups are left behind or seen as quote unquote acceptable losses. So, there's so much ableism to unpack here as well, and I'm interviewing long haulers on their perspectives and how news media covers long COVID too. As it's important for me to studies revolving around long COVID or the pandemic at large are patient centered, especially when some groups are disproportionately impacted.
Thank you for telling us about this, Kayli. Now, in the same lines, on October 22nd, 2024, Dr. Bonnie Henry said in a press conference, "If you've had COVID recently, you've had a boost in your immunity. This is a good thing." Dr. Arseneau, could you comment on this and the whole idea of immunity debt?
I think this is a perfect example of what Kaylee is talking about, is that Dr. Henry was talking about the concept of immunity debt as if it were a scientifically approved concept. The reality is that we don't know. And a lot of experts in the field say that they don't think that this is real and that it's being used to support policy decisions. And so, even if it is real, the way that it's explained makes it sound simple. But does it apply to all infections? Does it apply to all age groups? So, for instance, there's been a surge of RSV infections after the pandemic, after the lockdown has been removed. But if you look at Sweden, who didn't follow the same rules and kept their schools open, they have the same RSV incidents. So, you know, is it real? Maybe, maybe not. And if it is real, not that simple. But
Thank you,
right,
Dr.
but right now, it's being used to inform policy decisions.
Thank you, Dr. Arseneau. And Kayli, would you like to comment on this as well?
Yes, so some of you may know I do some science communication and myth busting on my social media through infographics. And Bonnie Henry mentions a lot this concept of hybrid immunity, which has no scientific basis, Dr. Arseneau just said. Our immune system does not function as a muscle. Not only do we have no immunity to this virus with hundreds of subvariants that's constantly mutating, it is exhausting our T cells and dampening our immune systems. And our population is abysmally vaccinated. Like June 2024 data indicated less than 5% of my age group even received the XBB 1.5 vaccine. And the federal data on vaccination levels in Canada is colored a nice, calming green, which is a disingenuous way to present this data. So, in this approach to herd immunity, they know that inevitably some people will die or become disabled from long COVID via repeat infections. So, once again, this comes back to biopolitics and necropolitics.
Connie, would you like to comment on this as well?
Yeah, I think I 100% agree with both Dr. Arsenault and Kaylee. Just I was thinking in terms of, say, if I were a layman individual, just no healthcare background, This is confusing and very misleading. It sounds almost like they're encouraging people to just catch COVID and deliberately saying that it's a good thing when it's not. Um, it's like when people say what doesn't kill you makes you stronger. Well, that's not the case for me. I don't know about other long COVID long haulers, and I don't think they were any stronger because of that. I wish, but our immune system basically went overdrive and took a major toll. I don't think I was any stronger, and I don't think it helped me prevent from any future acute COVID infections either. You also can't predict whether you'll get post COVID or long COVID. So, to say that just catch it, it's almost like, oh, you don't need this vaccine, you know? It also doesn't guarantee you that you won't get subsequent infection. What I mean, like I said, if you catch it again, it could be another boost to your immune for those of us who already had it the first time. And seriously, do we do this with all other kinds of infections, viral or bacterial? Like, do we just be exposed to become immune, to have a boost to our system? Like, I'm not sure if I'm reading this correctly.
Thank you, Connie and Kayli. Now back to Dr. Arseneau. So, Dr. Arseneau, we are really so thankful for your long COVID clinic. It has helped so many people. But could you tell us about some of the upcoming treatments or what's on the horizon for long COVID for treatment? And can you tell us about the NIH Recover Project in the US?
I mentioned the Recover Initiative earlier, and that's an NIH-funded research agenda. And right now they have about 30,000 participants. Initially, they were highly criticized for having mostly observational studies, but they've improved and now they've included clinical trials on different topics. And they're currently looking at 13 possible treatments. But like I said, most of these treatments are repurposed, things that already exist and things that, so that there may be medications that are currently used or other treatments like transcranial magnetic stimulation, IVIG, that are used for other conditions. And unfortunately, because it's not well understood, there's not going to be any drug company that's going to come out with a drug anytime soon, because what are they going to target? Especially when we have, so many different names and definitions and subgroups. So yes, there are a lot of good treatments out there. Unfortunately, none of them are curative.
Mm-hmm. Thank you very much for that answer. Now, in the same July 2024 study of post-acute sequelae of SARS CoV-2 by Dr. Al-Aly, it was found that the rate of long COVID has decreased from 10.4% of adults in 2020 with the ancestral strain of SARS-CoV-2 to 7.7% in unvaccinated adults and 3.5% in vaccinated adults in 2022 after Omicron. But even at 3.5%, this could mean millions of people having long COVID. And if we factor in millions of new long COVID cases with reinfection, the number of people potentially disabled with long COVID is staggering. And yet these days, when we look all around us, almost no one is paying attention to COVID, and few have heard of long COVID. Kayli, Connie, and Dr. Arseneau, could you tell us what needs to change and what your hopes are for the future of long COVID? So maybe Kayli again first.
Yes, so we need a multi-pronged approach that tackles the ongoing pandemic systemically. And this includes a top-down approach from the government and healthcare system, including launching a large communication campaign about long COVID awareness and risks. Many people still don't even know what long COVID is, but when I explain to them, they realize that they have it themselves or they know someone that does. So secondly, we also need investments poured back into the long COVID clinics and specific care for long haulers, instead of funding being cut. Over 400 million worldwide already have long COVID, so this is not going away. They need to make these investments back into the system. I promote the Swiss cheese model of epidemiology a lot, being that Swiss cheese is very holy and it has layers. So we cannot rely on one layer of Swiss cheese alone, such as vaccines only. We need as many layers as possible to help with prevention and rehabilitation. So this looks like clean air in schools and healthcare settings, mandatory masking, paid sick days, access to PCR testing, etc. So my hope is that more awareness continues until it cannot be ignored anymore. which I thought would have happened by now, but especially as more people realize they have long COVID and the workforce and economy suffer. There's a lot of research being done countrywide via the Long COVID Web researchers, which is the Canadian network of researchers and patient partners on long COVID. So there needs to be a light at the end of the tunnel with approved treatments and care, or a sterilizing nasal vaccine.
Thank you very much. I could not agree more. And Connie, what about you?
I think as a nurse, I wish there were more education and research on how this COVID infection could affect staff and patient care, in the sense where, say, are we using the proper PPE um, for say frontliners, for patients seeking care, or are we only selectively saying that we need an N95 for certain tasks only? Um, and then also the matter of getting adequate supplies of that PPE. I think a lot of us at one point experiencing that episode where there wasn't enough mask or other PPEs, and then the next day, maybe even to find out that the one you were using may be recalled. So I still remember it vividly, going to work like that, and I know that it's a lot of factors involved. It's not just one thing, and it's we're doing the best we can given the circumstances. But I wish there were more protection for our staff members so that we can serve more people. We have to be safe ourselves to provide safe care for others, essentially, and to prevent from further burnout and to retain our staff. Um, and definitely, I agree with Kayli. There's still a lot of work into research that needs to be done, whether for current long haulers, um, or the vaccine itself, or the acute infection phase itself. I don't wish anyone to get long COVID. It's so debilitating physically in all aspects of your life and also to our economy. Yeah, so I wish, wishful thinking, I guess. It's ideal in an ideal world with enough resources and whatnot. I wish that, we could find out on how to prevent from getting long COVID if we have to coexist with COVID. So, yeah.
Thanks very much, Connie. I totally agree with that as well. And Dr. Arseneau, could you weigh in on this?
I agree with both Kayli and Connie. This has to be a multi-pronged approach, but unlike other conditions, that there's extra challenges for post-COVID and long COVID. It's politicized. It's the victim of conspiracy theories, even by many of our own politicians, and it suffers from collective amnesia. Now, there's a study that said, what's the biggest impact of COVID on society? And the answer was COVID amnesia. And so I always say, don't fall into the trap of COVID amnesia. COVID is far from over. Patients with these conditions are expensive. So despite the fact that they're getting inadequate care most of the time, they're very expensive because of all the tests that they don't need that they get, all the physicians that they go see that they don't need to see. And so it's a false economy by healthcare providers to think that they're saving money by not putting money into the care for long COVID. You know, it's got to be more than me and Dr. McKay for an entire province. And luckily, the post-COVID clinics through PHSA are reopening, and Dr. McKay and I are acting as consultants. And one of the very simple ideas that we proposed is people should have access to resources right away, because there's studies to show the earlier that you have treatment and access, the better it is. And so for even patients who are not our patients, for Dr. McKay and I, we have a YouTube channel and we have a website. So we have patients from all over the world who are accessing our resources, and we've got a physician toolkit for primary care docs. And so, but it can't just be what Dr. McKay and I are doing. There has to be a more organized agenda, funding for moving forward for caring for these patients.
And really, many thanks to you and Dr. McKay for all your work on this. So, as we are beginning the 6th year of the COVID pandemic, the world has moved on, despite the fact that rates of COVID in BC and across Canada remain very high. After COVID infections, we're seeing higher rates of post-COVID conditions such as heart disease, strokes, diabetes, Parkinson's disease, and autoimmune disorders, as well as increasing cases of disabling long COVID. And we may not see the full effects of COVID and know the vast numbers of people affected for years to come. This is why it's so important to have Kayli and Connie, our long COVID survivors, and Dr. Ric Arseneau, director of one of the only long COVID clinics in BC, share their experiences with long COVID with us today. During the U.S. Senate hearings on long COVID, Dr. Ziyad Al-Aly said, "There is no long COVID without COVID infections first. To prevent long COVID, we need to prevent COVID infections with improved ventilation and improved vaccines. This includes vaccines that block infection, are more durable, and are variant-proof." But he was confident that scientists had the ability not only to make better vaccines, but also create new medications to treat long COVID. So we're going to take some questions right now. So this is from Lucia Lorenzi. What kind of diagnostic screening are people getting when they present with things like POTS, given that the autonomic testing facilities and expertise are very limited in BC?
I'll take that
So
one.
maybe,
You know, what's interesting about this is that POTS is easy to diagnose. And a lot of physicians out there mistakenly believe that you need a tilt table test. In fact, tilt table test is not as sensitive or specific for a test that you can do at home in 10 minutes. And so what we do is we get our patients to watch a YouTube presentation on POTS, and we get them to do something called the NASA lean test. You may or may not know that astronauts get POTS after they come back from the space station. And so Dr. McKay and I are preventing hundreds of unneeded consultations to neurologists and unneeded tilt table testing. And so we get patients to get a spotter, take their heart rate before they get out of bed, and monitor their heart rate for 10 minutes. That's better than seeing a neurologist or getting a tilt table test. After that, they can learn about the non-pharmacologic approach to treatment. SALT was mentioned earlier, and they can participate in group medication visits to learn about which medications are possible. So there are certain ways that you can deal with this large number of patients. For instance, we have a very non-traditional group-based clinic. So what we do is, there's studies to show that group medication visits are more effective. Usually you go to your doctor, they talk to you for 3 minutes about a medication, they give you a prescription. What Dr. McKay and I do is we have 50 patients at a time. We do a 20-minute presentation on the medication, 40 minutes of questions and answers, so that by the end of the hour, the patients are well educated about whether or not they would like to try a medication. If they decide to try, we write a note in their chart, we send that to their family doctor and the patient, and we prescribe the medication. So there's lots of things that the system can do to improve access to care while actually improving the care and not making it worse.
thank you very much. This next question, are there any plans to set up a dysautonomia clinic in BC with autonomic neurology, immunology, GI motility, cardiology, etc.? All the local specialists have stopped taking these kind of patients.
Yeah, so as far as I know, there is no plan. And a lot of the, I'm not sure that that there's anybody with an interest. Calgary is lucky, they have an interest. Dr. McKay is not only a POTS expert, but also a hypertension expert. And patients with these conditions have a different kind of POTS. So they're less likely, if you look at the diagnostic criteria for POTS, it says that your blood pressure doesn't drop or go up. And what actually happens is that a lot of patients don't get the right diagnosis because they have a low blood pressure. We've known this for decades for patients with chronic fatigue syndrome who have POTS. They can have a low blood pressure. But also there's a subtype of POTS called hyperadrenergic POTS where patients have high blood pressure. And obviously in that patient population, you don't use SALT. So as far as I know, there's no coordinated effort. And yes, many of the cardiologists who are seeing these patients are not seeing them anymore.
So we have a question. I was wondering if Dr. Arseneau could comment on the incidence of long COVID in vaccinated people. I've heard that 3.5% that was just mentioned, but I also heard the number as high as 10%.
Yeah. So the number 10% is what is, comes from the Dubbo study in Australia from a while back. And what they did in their infectious disease clinic, they prospectively followed patients with certain types of infections. And what they found is that at 6 months, about 10% of patients came back with fulfilled criteria for chronic fatigue syndrome. And that's where the number 10% has been bandied around. And that number has been shown in the initial part of the pandemic. But that doesn't take consideration of what happens when an infection becomes endemic. And it also doesn't factor in what happens when you add vaccination. And so the numbers that Dr. Cole presented show that the risk is reduced to 7.7%, and that if you're vaccinated, it's down to 3.5%. So that's why you see these different numbers bandied about.
So we have questions for Kayli and Connie. So what have your experiences been like accessing healthcare in general? So whichever of you first, go ahead.
I'm happy to go first. It was, I wouldn't say it was super hard for me. I'm very grateful for having a great, amazing GP who has been supportive of me from day one of this whole journey till now and ongoing. Um, but yes, when I was referred to other specialists, not Dr. Arseneau, obviously, but it's not that they were entirely dismissive. They were very hesitant to order further diagnostic because they felt it was symptom based only. It was, and they didn't know a lot about it. Um, I got one even telling me that some don't even believe in it or in POTS. And so it was hard. Like, had I not worked in healthcare, I might not know what to ask for, what questions to ask, what diagnostics to push for. I did push for some diagnostics because at the time I didn't know what was going on. It just felt so scary, right? I just wanted to find out, hey, is something indeed and are we able to detect it through scans and whatnot? Um, and then the doctors that have seen me, they were all, "Oh, okay, we'll do it." And then when I read the report on our meeting, they were like, "Oh, the patient was anxious, so we decided to order for it." So when I read that, I was like, "Okay, it's not just because I'm worried, I'm anxious. I'm worried for legit reasons. Like I'm feeling all these symptoms. I didn't make it up. I wish I could make it up and then be better one day, but so that was kind of frustrating. Um, that's yeah, in general, that would be my experience with accessing healthcare.
Thank you. What about you, Kayli?
Yeah, I'm very privileged. I would say that I have a family doctor in BC. So I know how short we are of that. And she's always been very supportive and always believed me. I know it hasn't really been the case with many long haulers. I know who've been medically gaslit or like Connie said, like chalk it up to anxiety or it's all in their head. Um, I found that my family doctor didn't really know much. Like, although she believed me, like she felt there's something she could really do. So I felt passed off to like other specialists or um, there's an assumption that the long COVID clinic run by PHSA would solve all my problems for me. And evidently that wasn't the case. Even when I went to the ER this past spring, when I had some extreme chest pain and other symptoms, like the ER doctor didn't really know anything. They couldn't do anything for me there. It was just like a waste of time. And I also coincidentally saw Dr. Ric Arseneau shortly after that. He was like, "Oh yeah, that's costochondritis. Like that's common in any CFS." And I'm like, "Oh, okay." He knows right away what it is. And here I was in the ER and hospital trying to explain to everyone that I could, like, yeah, long COVID. You know what long COVID is? And there's so it honestly felt like a bit ridiculous. I'm having to do so much of the educating across medical professionals and people I come across. There was an internal med doc I saw as well to do like cardiology related stuff, and she I had to ask her to prescribe me low dose naltrexone. She didn't know a single thing about it, so she let me take the reins on it, and I relied on the BC Women's Hospital handout sheet to learn about doses and titration. But yeah, I don't know. I would say I'm a more privileged experience though, just because I do have a family doctor.
Thank you, Kayli. How can we expand patient access to care, treatment, and diagnostic testing? How can we combat false scarcity of care, testing, and treatment?
I think the problem with doing that is it can't start from the grassroots. So the four of us here are in the grassroots, and we're struggling, and we're making I think a reasonable dent in the need, but unless it comes from the top down, because Dr. McKay and I, we look at our clinic, and people might look at it and say, well, that's weird. Why are you seeing 50 patients at a time? And is that okay? And so, unless there's a real initiative from the government to do something, it's going to rely on people like the four of us who are kind of yelling from the grassroots.
This is kind of in line with the same question, but are there any tips for patients whose family physicians or other providers are dismissing or minimizing their long COVID symptoms?
Yeah, I mean, that's easy. Go to our website and watch one presentation called Family and Friends. Go to our YouTube channel. There's it's called METV, which stands for Myalgic Encephalomyelitis TV, and watch Family and Friends. And if you look at the number of views, it's been viewed by almost 15,000 people. So obviously there's a lot of people out there who are watching this, and this will give you an overview of these conditions, and we'll put it in context of what we already know.
And I think, Ric, we talked in the past about having you present to my journal club of 90, I think it's 95 or 96 docs. So we can maybe contact you about that again. Because I think if you directly present to a captive audience, I think this will be very educational as well. What responsibility do long COVID and post-viral clinics have to keep up to date on research, etc.?
I don't think there's any kind of responsibility. It's self-imposed. So, for instance, in our clinic, we have Dr. McKay just recently went to the Canadian conference, and she did a presentation for our patients on what's the research update. She's going to the Barcelona conference in November, and in December we have a special lecture on what's the update from Barcelona. And so, we've been doing special lectures for a week. And this is another unusual thing, is we have 150 to 350 patients who participate at the same time, and we record many of them for our YouTube channel. And so far, we've actually done 90 different topics. Mm-hmm. And so Dr. McKay and I are, we just use self-directed desire to keep up, but there's no actual mechanism or responsibility that's been assigned.
Any other questions? Yeah, it's very interesting. So I tell my medical students when they come to my clinic that this is a field that you are going to have to know about, because in your careers you're going to be seeing lots and lots of long COVID patients, and you need to know about this. So
even before the long COVID and the COVID pandemic, the Mayo Clinic, they are at the lead of the forefront of this. They estimated that 1 in 5 visits to a family physician is related to these types of conditions, even before the pandemic.
Yes.
And the Canadian Census in 2007, the report by the Canadian Census in 2017 estimated before the pandemic that 1 in 5 patients had chronic fatigue syndrome, fibromyalgia, multiple chemical sensitivities, or related disorder. So even before the pandemic. Mm-hmm. Now you can imagine what's happening.
Mm-hmm. So I don't see any other questions coming up. So we will probably have more questions after, and maybe direct that to our interviewees if there are any questions. So I'd like to thank Dr. Ric Arseneau, Kayli Jamieson, and Connie Chen for taking the time to join us today for this discussion on long COVID. I'd also like to thank Kara, our IT person, without whom this live briefing would not be possible. And finally, I would like to thank our listeners today for joining in. Thank you very much.